Welcome back to Maryland Health Today. I'm Ellen Beth Levitt. We're talking about lung cancer on the show today. My guest is Dr. Richard Badaforano. He's the head of thoracic surgery at the University of Maryland Medical Center, and Dr. Badaforano is also an associate professor of surgery at the University of Maryland School of Medicine. And before the break, we were talking about smoking and how big a contributor that is to lung cancer. And lung cancer is the #1 cause of cancer death for both men and women. Is lung cancer the same as other cancers in terms of if you detect and diagnose them earlier, the prognosis is better for treatment?
It's exactly the same. And so we spend a lot of time working with patients and to try to find patients with early tumors, just like you would with breast or colon or other prostate cancer. But also what we do is we spend a lot of time making sure that what we think is an early stage cancer is really an early stage cancer.
Are there any symptoms in the early stages?
No, in general, most patients feel perfectly healthy. Let's say, for instance, they were going to have surgery for another reason, like they're going to have knee surgery or hip surgery, and they get a chest x-ray as part of the process, and all of a sudden they see a spot on their lung. When we work that up and talk with patients, they say, there's no way I have lung cancer. I feel too good. And so that when they're small, most patients won't have any signs or symptoms. As the tumors get larger, sometimes they can cause blockage of the air passages and they can get pneumonia, so they'll have a cough or fevers. Other times they'll start coughing up blood. But again, when patients present with symptoms of lung cancer, usually the tumors are more advanced, the cancers are more advanced.
Well, when a spot is found on the lung, and I know that's not unusual, people do get chest x-rays or CT scans of their chest for other things, and there might be a small shadow or spot, and the radiologist isn't sure exactly what that is. What is usually done in those cases?
Well, usually it's identified first on a chest x-ray, and then we use the CAT scan as a way to really localize on it and really zero in on it. And the chances of something being a cancer is directly related to the size. So something that's an inch or 2 inches in diameter is much more likely to be a cancer than if it's 1/8 of an inch in diameter. And then also we take into account the patient's own history. That is if you're a young person who's never smoked cigarettes and they have a spot on their lung that's 1/8 of an inch, we're much more likely to follow them for their, with repeated CT scans. On the other hand, if you have a 65-year-old person who's been smoking since they've been a teenager and they have a nodule on their lung that's 1 inch in diameter, well, we're much more likely going to be concerned that that represents a lung cancer.
What are the main types of lung cancer? I know there are several different types.
Well, we break it down into 2 groups. One would be small cell lung cancer, which represents about 13% of all lung cancer is small cell lung cancer. And that lung cancer has a very kind of what we call a virulent or aggressive course. That is, we can have small spots on the lungs in which those tumor cells have acquired the ability to break off and go to the lymph nodes in the mediastinum. And so when patients have small cell lung cancer, the vast majority of those patients are not treated with surgery because the tumor cells have broken off and going to other places in the body which wouldn't be treated by a surgical procedure. The other type is non-small cell lung cancer, which is a large group. It represents about 85% of all lung cancer, and that can include large cell lung cancer. It also can include adenocarcinoma of the lung or squamous cell carcinoma of the lung. And so those tumors are non-small cell, and because many of those patients will have localized spots and the tumor cells haven't broken off and gone other places, they're the best candidates for surgery, especially in those early stages.
Because you predict that it's more localized and it hasn't spread yet.
Correct, and so that the operation we tend to do for non-small cell lung cancer would be a lobectomy, in which we don't just remove the spot itself, but we remove that section of the lung in an effort to take all those lymph nodes and get the best cancer operation. And so, on the other hand, if tumor cells have spread either to lymph nodes in the center of the chest or, of course, to other places in the body, then trying to solve the problem with surgery is not likely to be effective. And so in those situations, we also work with our medical oncologists who specialize in using chemotherapy for lung cancer and our radiation oncologists who use radiation therapy for lung cancer and come up with a coordinated plan trying to mix those two in a very organized way to get the best chances for cure.
And at the University of Maryland, Marlene and Stuart Greenebaum Cancer Center, there are teams of specialists, right? So for lung cancer, you have a whole team of yourself, the surgeon, and also the medical oncologist and the radiation oncologist who specialize in cancers of the lung.
Yeah, and not only are we all available to patients, but we actually work in a very close-knit team, so that when patients are seen by us, we often see them at the same day, which is very convenient for patients. And also they can then get an understanding of each of the different types of treatment, what that will entail for them, but also the benefits and then maybe the side effects associated. So at the end of seeing us at the cancer center, what happens is that they have a pretty good idea of not only their problem, but how we're going to all work together to try to help them with it.
I've heard that staging for lung cancer is very important. What is staging?
Well, staging means is that we've agreed with the American Cancer Society, for instance, that stage 1 tumors in the lung would be just a spot by itself that's small, with no evidence of spread to any of the lymph nodes, either close to the spot or anywhere else in the body, and no evidence of cancer anywhere else in the body. That would be a stage 1 tumor. If the lymph nodes closest to the lung cancer have cancer cells in them, then that would be a stage 2. And then if the lymph nodes in the center of the chest are involved with lung cancer tumor cells, that would be stage 3. Stage 4 disease would be those patients with tumor cells that have broken off and either gone to the brain, liver, the lung, other lung, or the bone.
And can you, how do you determine the stage? Is that a biopsy?
Well, it's a combination of using our X-ray tests. So we usually will begin with a CT scan of the chest, and then that will also be followed with a PET scan, which takes advantage of the fact that cancer cells will often concentrate a special tracer that we can give them. It's a non-invasive test, and that gives us an understanding whether maybe some of these enlarged nodes, if they also take up the tracer, they would more likely be associated with cancer cells that have traveled there. But it's always important to make sure that we verify that our X-ray tests are really giving us the correct information, and that'll require a biopsy.
Can that be done in a minimally invasive way?
We try to do all our biopsies minimally invasive in that regard, and so we begin to check those lymph nodes in the center of the chest. We'll make a small incision just above the breastbone and about 1 inch in length, and what we were able to do is actually go down into the center of the chest through that small incision and biopsy the lymph nodes adjacent to the airways that would potentially drain cancer cells, and then they would be biopsied. That's really critical because if there are tumor cells in the lymph nodes in the center of the chest, again, that's when we begin that whole process of using the combination of chemotherapy, radiation therapy, and surgery in an effort to give those patients the best chance for cure.
How soon after the biopsy would a patient learn what stage they have?
We give the pathologist usually about 2 days to be absolutely sure that they can process them and look as closely as possible. But again, we try to keep things moving for patients so that this idea of having a spot on your lung or a lung cancer that you know about to really getting going on therapy, we try to make that as short as possible.
And I understand that the sequence of the different therapies is very important. There's been research recently that has found that the sequence, either chemotherapy first or radiation first or surgery, that's important in how successful the treatment can be. Is that correct?
For sure. And what happens is if we overlap, for instance, chemotherapy and radiation therapy for patients, the cancer killing effect is better. It's even more than additive. But yet the associated side effects can be higher. The radiation oncologists have really taken advantage of all the new computer technology. So their machines, the radiation machines that they use, are all connected to three-dimensional computers, so that when they give their therapy, it's with pinpoint accuracy.
And that way they can give the highest dose of radiation possible
to the tumor itself,
right?
And then spare things like the spine, the heart, and other critical structures where we want to decrease the amount of radiation exposure. Similarly, the medical oncologists have been able to work with their cancer chemotherapy agents in a way that the side effects are much more tolerable. Many patients will get their chemotherapy as an outpatient because it's so well tolerated. And now what happens is the idea of using chemotherapy, radiation therapy, and even following it with surgery is very possible because the whole process is tolerated by patients so much better.
When you do surgery for lung cancer, do you normally take out one of the lobes?
That's the goal of every cancer operation, is to take that lobe, which not only takes the tumor itself, but the draining lymph nodes. Occasionally, a more extensive operation might be required. For instance, if a tumor spans that fissure between the upper lobe and the lower lobe, for instance. Sometimes we might have to take the whole right lung, or if it spans, takes the middle and lower lobe, we'll sometimes take the middle and lower lobe on the right side and save the upper lobe. We spend a lot of time as surgeons trying to dissect out the lung and actually do a good cancer operation, and yet at the same time preserve as much lung as possible, because that's going to be associated with a better quality of life for our patients after they recover from surgery.
Sure. Can people live a near to normal life with a lobe removed or 2 lobes removed?
Well, about 2 days after surgery, they won't believe it, because there's the discomfort of surgery and there's the whole process of getting their strength back afterwards. But most patients, about 2 to 3 months after surgery, can resume all of their activities. People who like to bicycle ride or swim,
really?
Or even hike, they won't notice a difference until they really push themselves to, at the greatest limit. Now, of course, if a person has bad emphysema from years of smoking, they're going to be affected much more than somebody who was maybe a lighter smoker who didn't develop the emphysema. It all depends on how much reserve they have in the remaining lung that we're able to save for them.
Is there an upper age limit to the surgery for lung cancer, or can people even well into their 70s and 80s have the surgery and have a good prognosis afterward?
Well, I think that if a 70-year-old person develops lung cancer because they smoked when they were in their 20s and 30s and are otherwise quite fit, they have no significant heart disease, they have no significant underlying emphysema, then we've actually operated on patients in their mid-80s in those situations, patients who are chronologically 80 but physiologically a lot younger. On the other hand, there are some patients that come to us in their 50s and 60s who have associated heart disease and bad emphysema, and trying to do a lobectomy, for instance, wouldn't allow them to have enough lung at the end of the operation that's functional for them to actually undergo that. So it just depends, not chronological age, really physiologic age.
Okay. We only have a couple minutes left, but I wanted to ask you about another condition that thoracic surgeons and experts such as yourself deal with, and that's a collapsed lung. What is that, and what could cause a collapsed lung?
Well, collapsed lung is actually a pretty common problem, and we see it after car accidents or other accidents where people fall and maybe break a rib, and that cut end of the rib can puncture the lung just like it can puncture a balloon. And what happens is the air from inside the lung escapes and gets trapped between the ribs themselves and the chest cavity and start pushing on the lung so it becomes collapsed. So it's a vicious circle. The first thing we do is actually put a small tube in to then decompress that air under pressure, drain it out, and allow the lung to re-expand. In the vast majority of patients, the lung seals pretty quickly, and so that tube evacuates that trapped air, the lung re-expands, and then we can just remove the tube. Occasionally, patients will have small air blisters, or what we call blebs, on the surface of the lung. And in those cases, if the bleb doesn't seal on its own, then we go in and, using a minimally invasive technique, using a camera for vision as well as small instruments, we're able to remove that area of diseased lung and allow the lung to re-expand.
So you don't have to make a big incision?
We always try to do it through small incisions. And with the new video instrumentation, we can do a lot more than we could even 5 years ago.
If someone had a collapsed lung once, are they at risk of it returning?
Yes, and it varies from person to person. I think that on the chest x-ray or even the CT scan, if we see associated blebs, and they're really obvious to see on the CT scan, then oftentimes we'll recommend to the patients to get those blebs removed to decrease their chances of developing another collapsed lung.
You mentioned that through an accident or trauma or something this can happen, but can it also happen to someone who hasn't hurt themselves?
Can happen. The patients are just doing their normal routines and all of a sudden they feel some discomfort in their chest, and it's a painful experience, and then it just seems to become a dull ache. But over time, as the air escapes from the lung and gets trapped, then it presses on the normal lung so it can't expand, and that's when the patients get short of breath doing normal activities.
Are they sometimes misdiagnosed and told, oh, you just have the flu or something?
Yes, but as soon as the physician listens to that side of the chest, what will happen is there won't be a lot of air movement, and that's a sign that we should probably get a chest x-ray.
We only have a few minutes left to the program, but I wanted to give you the opportunity to leave the important message regarding healthy lungs, and I know that you talk a lot about not smoking.
Right. I mean, that message just cannot be repeated enough, because as we look around, still a fifth of all the people in the state of Maryland are continuing to smoke. So I think if you're a smoker now, do whatever you can, and we'll help you at the medical center to stop smoking. for those patients who've successfully stopped smoking, don't forget that if they develop lung cancer in the future, we're there to help them.
Thank you very much. My
Thank you.
guest has been Dr. Richard Badaforano. He's the head of thoracic surgery at the University of Maryland Medical Center, and he is also an associate professor of surgery at the University of Maryland School of Medicine. If you have any comments or questions about this program, please contact me by email, eblevitt@umm.edu. And if you'd like to reach Dr. Badaforano or any other University of Maryland physician, call 1-800-492-5538 or visit the website where you'll find a great amount of health information and be able to see other Maryland Health Today programs. That address is www.umm.edu. Take good care of yourself, and we'll see you next time for Maryland Health Today.